Welcome everyone to our MANNA Institute academic seminar series. Today, the title of our webinar is Malnutrition Assessment, Past, Present, and Future. Adrian, would you? Thank you. So I'm going to give you a short introduction today. I'll talk a little bit about the MANNA Institute, and that will be followed by our seminar presentation. And at the end of our presentation, we'll have time for questions and answers. And please put those in the chat, and I will be moderating those and asking those to Dr. Compher. Next slide. So the MANNA Institute sponsors a biannual academic seminar. We are a division of MANNA, and our role here is to explore the impact of nutrition on health for people with serious illness. We are the research and evaluation arm of MANNA, but we also educate healthcare practitioners and consumers, and we disseminate and share findings and best practices in order to improve service delivery and healthcare transformation, especially in regard to the use of medically tailored meals and medical nutrition therapy in healthcare. We are also an ambassador to Malnutrition Awareness Week, which was held this year from September 19 to 23rd, and was an initiative of FASPEN. There's a lot more great information that can be found in a series of webinars that were offered that week. So especially for registered dietitians on the call, if you want more updated information, please access and watch the series of webinars that were offered during Malnutrition Week in September of this year. So today, I'm very honored to introduce our speaker, Dr. Charlene Compher. She is Professor of Nutrition Science and the Shearer Chair of Healthy Community Practices and Director of Nutrition Education Programs at the University of Pennsylvania. She's also Director of Microbiome-related Diet Assessment Research at Penn Children's Hospital of Philadelphia Microbiome Program, and she's Director of Clinical Initiatives at the Penn Center for Nutrition Science and Medicine. So thank you for being here with us today, Dr. Compher, and I will turn the presentation over to you. Thank you.
Thank you so much, Julianne, for the gracious invitation to be here. It's truly my delight because as I told Julianne and Adrian earlier, I care very deeply about malnutrition. This is a topic that I've put a lot of my energy into over the past 10 years, but as a registered dietitian myself, who has been in clinical practice, my entire career, I've been dealing with malnutrition. It's just reaching a new level at this point in time. So what I'm going to show you today is give you something of an historical perspective about malnutrition, talk about the current approaches that are used primarily in the US today, and we'll look at what are the clinical outcomes associated with malnutrition, because those are the targets that services like MANNA can impact, and what are the outcomes associated with treatment of malnutrition. I hope you're aware of the first nutritional outcome study published by Hiram Studley in JAMA in 1936. This was in a fairly small group of patients with peptic ulcer disease, but what he observed was that when they had less than 20% weight loss, the mortality, this was benign peptic ulcer disease, the mortality was 3.5%. When they had lost more than 20% of their body weight, it was tenfold higher mortality. You've also perhaps seen the skeleton in the hospital closet. This paper by Charles Butterworth was really a pivotal turning point for our field. because it called out the problem of how difficult it was to work on malnutrition in the 1970s. Often patients did not have height and weight recorded. It was very common to make people NPO and run glucose or saline. There was poor communication across members of the healthcare team. The enteral feedings were not adequate. There were many days until nutritional repletion, and just an overall failure to appreciate the increased needs of these people with infections and illnesses. Fast forward about 10 years, and our Canadian colleagues, Detsky and Kirsch-Gigiboy, published the subjective global assessment. This approach is subjective because it depends on information, self-reported information from the patient, and also a physical exam, nutrition-focused physical exam. However, it does not include laboratory markers, biomarkers, nitrogen balance, any measures. And so the weight loss that they look at is what was your weight loss in the last 6 months. And then you ask the past 2 weeks to see if the pattern has stabilized or improved. You ask about change in dietary intake and how long it happened. What was the functional capacity? Were there GI symptoms of longer duration that would impact their nutrition status? And this was the first paper that also used the diagnosis to define metabolic demand. There were some diagnoses that were more demanding metabolically, meaning you need more calories. Whoop. The physical exam includes loss of subcutaneous fat and muscle wasting, and some assessment for edema. And then patients are classified as SGA-A if they're well nourished, B if they have more than a 5% weight loss that has not stabilized, they have low food intake, mild fat loss, and severely malnourished if they have lost more than 10%, and if you can see severe muscle wasting. Fast forward again, almost 20 years, and this was an international consensus guideline committee that I was honored to be part of because of my role as guidelines chair for FASPEN at that point. We met with multiple meetings with international leaders in the field of malnutrition, trying to establish a consensus model that could be used so that we would be speaking more the same language. And what we wanted was to tie the clinical diagnosis, what's going on, what's causing any inflammation, if there is inflammation. And we did this by diagnosis. So if there was either limited access to food or anorexia nervosa, there does probably not much inflammation in that condition. We term that starvation-related malnutrition. If the inflammation is chronic and mild to moderate, as in organ failure, sarcopenic obesity, general rheumatoid arthritis, then that was chronic disease-related malnutrition. And if it was acute and severe injury, of severe degree, as in major infection, burns, trauma, the patients in your ICU, that was acute disease or injury-related malnutrition. This model was adopted by the Academy of Nutrition and Dietetics and FASPEN in 2012 as the backbone of the consensus guidelines for identifying malnutrition. These have now been recently renamed as AIM, Academy FASPEN Indicators of Malnutrition, and they require the possession of two of these for moderate malnutrition, weight loss of 5% in a month, food intake less than 75% of needs for more than a week, mild loss of muscle or fat mass, mild edema, and then severe is greater weight loss in a month, lower food intake, and moderate or severe loss of muscle mass. What we came to realize, though, is that by 2016, we had colleagues in Canada who used the SGA. We had a big rollout effort in the US to establish AIM in the practice of clinical dietitians. Our colleagues in Europe were using a different system altogether, and our Latin colleagues were using variable approaches. But everybody was looking at the same situation. I'm really proud of this because it happened during my term as president at FASPEN. We gathered these global leaders, two from each of the major parenteral enteral nutrition societies, and we deliberated for 3 years before we came to consensus about the approach that we now call GLIM, the Global Leadership Initiative on Malnutrition. What we wanted to develop was a tool for busy clinicians, physicians, nurse practitioners, people who are in practice with limited time and honestly very limited nutrition expertise. But because we kept seeing people coming to the hospital sicker and sicker and more malnourished, we thought that this needed to be identified earlier. But the approach needed to be simple enough that someone with minimal training, but with a skill set, could recognize it. We also really wanted it to be a framework under which all of these other diagnostic approaches could fit. So we wanted to use the same variables that everyone was using and make it easy for us to say, well, if you're SGA B, then that's the same as moderate malnutrition with GLIM, for example. And really, at the end of the day, our future goal is to have this be a method where people report their findings in a standardized way so that we can make comparisons. We want to know what are the best approaches for treating malnutrition. And it's hard to get at when people are reporting their data in very different ways. One of the first things we did was make a comparison of all of the tools that were being used at that time. The screening tools are on the left here, these first four, and then these are the diagnostic tools that were in effect. But notice that all of them, essentially all of them use reduced food intake. All of them have some way of considering disease burden by this point in time. All of them consider weight loss. Some of them consider body mass index, and some of them do the diagnostic tools all do a physical exam looking for loss of lean mass. What we came up with by 2018 was this approach. So as in the US and part of the nutrition quality indicators, the first step is to use a validated screening tool. And if someone looks like maybe they may be malnourished, then you do the assessment. The phenotypic characteristics, or what you can see, would include non-volitional weight loss, low BMI, and reduced muscle mass. And the etiologic, or why this happened, would be reduced food intake, or it could be malabsorption, or disease burden, or an inflammatory condition. So if a person meets one etiologic and one phenotypic, then that is considered malnourished. And then to determine the severity, you go to the weight criteria. And what we see here is a comparison. I put both GLIM and AIM on this table to show you the similarity between the two. GLIM is 5 to 10% weight loss within 6 months. The Academy has 5 to 10% in 6 months, or 10 to 20% beyond 6 months. GLIM has a body mass index variable that may well fall out over time, but there are some data linking low BMI, particularly in older European adults, with poor outcomes. The Academy chose not to use BMI, and the reason is we wanted the process of assessing for malnutrition to include everyone. We wanted dietitians not to say, well, this person's BMI is normal, so end of the day. Or this person has a BMI of 17, therefore they're malnourished. There's more to it than that. You need to look at the whole person. Both agree that if there's mild to moderate deficit, either by some device like body bioimpedance analysis, or if you're lucky enough to have a CT scan read for lean mass, or by the nutrition-focused physical exam. And with severe malnutrition, greater than 10% within 6 months, greater than 10% in 6 months, and a yet lower BMI criteria. And in addition, there are lower still BMI criteria for use in Asia, for good reason. People are smaller. Okay, so then we have to think, well, how good are these? So we need to compare these methods because we don't really have a gold standard. We use a semi-gold standard. The SGA, because it's been around such a long time and has been associated with so many, as a predictor of so many poor outcomes, this is typically what's used for essentially all the screening tools and malnutrition approaches. So these are the publications that, as of about 6 months ago, had addressed malnutrition by the SGA or by GLIM. And notice that they're fairly similar. You will see differences in the rate of malnutrition. This study is hospitalized cancer patients, and it makes sense that they would have a higher prevalence of malnutrition. But they agree fairly well. And then you look at what are the sensitivity or the true positives that are identified with this approach, what are the true negatives, and you can see that both are 85% or above. So that's really good, actually, sensitivity and specificity. And we see very similar numbers with the AIM approach also. So the question in the US today, sometimes dietitians say, well, do I need to give up AIM? What do I do with AIM? I've been trained, I know what I'm doing. I suggest that we can use both together. I'm aware that in my health system, and I think it's true generally, there are many practice areas where physicians do not have dietitians locally available, and yet those patients still need to be recognized when malnutrition is beginning to develop, not wait until they're admitted to the hospital and they're really further down the line to severe malnutrition. It's also likely that when physicians begin to use GLIM in their clinics, they will make more referrals to dietitians for further workup and also for treatment plans. We also know, both on our data at the Hospital of the University of Pennsylvania, and I just saw a presentation from a very innovative group in Australia, the hospital electronic medical record can link the variables from the AIM approach done by dietitians to the physician's diagnosis area. And the nutrition assessment and care plan data can be appended. So it gives us the possibility of having agreement excuse me, about our assessment of this important finding. Well, why does it matter? These are forest plots showing you what we know about the outcomes associated with malnutrition using either GLIM or AIM approach. And these are the means and the medians and 95% confidence intervals. And you can see that they're all on the side of increased hospital mortality when patients are identified with malnutrition. The same is true for 30-day readmissions here. These are studies in malnourished patients in the US. And I cheated a little bit by highlighting in red Hudson, because this is a Penn paper that we're pretty proud of. And those who were malnourished had much higher odds. The group overall, the odds are almost twofold greater odds of mortality in the hospital when they're malnourished. These are 30-day readmissions, and overall, more than twofold increase in 30-day readmissions. Even though these are very varied patient samples. Well, what if we treat malnutrition? This is a very interesting study. This is a systematic review and meta-analysis looking at all of the studies they could find that were looking at nutritional interventions stratified by publication year. And what you can see, this is readmissions in this first one. And the mean, the kind of the green diamond there shows you that when they had nutrition support, there was a 30% reduction in readmissions. And these are the trials published after 2014, because the earlier ones were before we had tight glycemic control. Sometimes we were overfeeding people. We now have careful line care. And notice that this is still significant reduction in readmissions of about 25%, even under today's complex acuity situation. They did the same thing for mortality, and mortality is a harder outcome. You typically need a much larger sample size, and these are not so big. So mortality was not significantly different when they were all combined, but when they were the studies published after 2014, mortality was also reduced about 25%. So this suggests that treating malnutrition with nutrition support is an effective approach. This next study is a randomized trial in patients in Switzerland, about 2,000 patients. They were randomized to either standard of care, which is on the right here, or to a much more intensive dietitian's effort to deliver goal protein and energy intake. So what they did was they focused on oral nutrition, And then they reassess, and if they were meeting their goals to greater than 75% of caloric and protein targets, they were fine. If they didn't, then they would go to enteral feedings. And if they didn't meet their goals that way, they would go to parenteral nutrition. This slide on the left shows you the proportion of patients with adequate caloric intake at the top. And you can see that there really is a significant difference in caloric intake from day one over the 10 days that they observe them. And this is the same is true for protein intake. These are the outcomes on the right. The A panel is a composite outcome that includes mortality and I think infections. And the red line is the intervention group. So you can see this is the proportion of patients with no adverse outcomes is much higher, and the p-value is 0.02 in those who had the intensive intervention. The bottom panel is all-cause mortality, and you can see that that's also statistically different. These are two smaller studies looking, but they're interesting because the first is in Wales, 143 elderly patients admitted through the emergency department. They were randomized to either oral nutrition supplements and snacks versus usual hospital care. And those who got the oral supplements and snacks had reduced hospital length of stay by 9 days, which is huge. And 30-day readmissions were also decreased significantly. In German patients who were at nutrition risk, they were randomized to diet modification plus or minus oral nutrition supplements versus usual care. They had fewer complications in the intervention group and lower 6-month readmissions. This is an interesting one for you because it's about medically tailored meals, and it's a fairly large sample of about 1,000 people. About 500 of them got 10 meals a week, and then another 500 did not. The ones with meals had fewer hospital readmissions. This is half the hospital readmissions, and fewer skilled nursing facility admissions, 70% reduction. And the authors estimated the potential cost savings in medical costs of more than $750 a month if all of them had received these meals. This is another randomized trial led by Deutz, and it happened in the US. Older adults who were assessed to have moderate or severe malnutrition were randomized to 2 cans of oral nutrition supplement or a placebo every day during their hospital stay and for 90 days after discharge. And you can see that they did blood draws, quality of life measures, etc. And what we see in these about 600 patients is the mortality is, this is the survival curve, not the mortality curve, survival. Those with the enteral supplement, the oral nutrition supplement, had much better survival. But what's also interesting, that they concluded that 2 cans of oral supplements a day provided within 72 hours of hospital admission and 90 days post-discharge was associated with decreased mortality. But this is the nutrition status, and we don't do this often enough. They evaluated the nutrition status at baseline, day 30, 60, and 90. And what you'll notice, SGA is normal, B is moderate, and C is severe. Notice how the proportion of SGA-C is going down at every point through day 90. And it was, in fact, significantly different in the treatment and the control. And the bottom part here shows you the change in body weight. Those who got the supplements every day had increased body weight by day 30, 60, and day 90 relative to these are, these at the later days, they are trending, but they certainly look significantly different. So just to summarize, we believe that both the AIM approach and GLIM are really important. The GLIM approach may be most useful in clinical settings where they don't have optimal nutrition skills and resources. And this can be in the US, but part of what we were after also was a model that could be used in developing countries who have even fewer resources than we do. We believe that our ability to identify the best approaches to treat malnutrition will be aided by our publication of variables comprising the approach to diagnosis of the condition. And a standard approach opens the possibility of randomizing patients, block randomization by malnutrition status, to determine is exactly the same approach equally beneficial with moderate as with severe malnutrition. There is a lot more that we can learn, but I hope I've convinced you that we are finally beginning to speak the same language so that we can get from here to there. Thank you for your attention.
Thank you so much, Charlene. At this time, I want to encourage everybody to put your questions in the chat so we can have a discussion with Dr. Compher. So also, feel free, I think you can raise your hand and speak as well. I will start with a question. And we are actually having trouble seeing the questions in the chat. Charlene, do you see them in your chat at all?
No, I don't. I was just looking.
Yeah, okay. I'm going to start with a question for you. So as you know, and we've had many discussions about this, MANNA is a medically tailored meal provider out here serving people in the community. I'm really interested in continuing malnutrition assessment in a community-based setting. And so the GLOM criteria is probably more useful to us. So just to make sure that I understand correctly, so if people are diagnosed with malnutrition in the hospital by, whatever set of criteria, and we were to continue, and let's say somebody was referred to MANNA and we were to continue that out in the community, we could use GLOM criteria in regard to something that's, solid for us to assess might be change in body, continue to assess might be change in body weight, and dietary intake, nutritional intake over time. And so we could follow if someone gets, we would consider them continuing as mild or moderate or severe malnutrition by those criteria and intervene appropriately, or follow that they in fact are still doing well after hospital discharge. Is that the correct way to kind of look at that?
I think that would be a great way to do it, considering that you know what meals you're giving them. One way to find out how much of the meals they're eating is to ask them on one day to take a picture of their breakfast before they eat it and after they're done, their lunch before and after, etc. And then you have the advantage, frankly, at MANNA of being able to get a strong sense of, are they eating 25% of what we're sending them? Are they eating 100% or, you know, something in between? And that would be wonderful. The body weight when you're in the community is always going to be self-report. But when we're dealing with malnutrition, as opposed to obesity, people are, I think, are more likely to be honest about their weight. And so looking for trends in weight loss, and maybe also asking, are their ankles swollen? Is there something going on where you can say, well, maybe all of this weight is gained, or maybe the edema is less severe than it was when they went home. But I think that would be fabulous and would be really a good quality indicator for MANNA.
Well, thank you so much. Appreciate that. So we do have a question now coming through the chat. We had a little bit of technical difficulty there, but the chat is working now. So please put any questions that you have. This is in regard to FASPEN malnutrition criteria. And the question is, for energy intake and for malnutrition in the context of chronic illness, why is severe malnutrition defined as less than or equal to 75% of estimated energy requirement for greater than or equal to 1 month, while moderate is defined as less than 75% of estimated energy requirements for greater than or equal to 1 month? This seems backward to me. Do you know why this is?
I don't know a rational reason why this is. My suspicion is that it was a typo in the publication, because I agree with you, it doesn't make sense. But any patient who is having less than 75% of their estimated intake certainly is somebody we would all keep an eye on and try to push forward. This is one of those mysteries that I haven't been able to solve. So don't worry about it. It's just worry about the patients. Wow.
Thank you. And so I have another question for those RDs that are interested in CT scan analysis. How do you suggest we get trained?
Oh my. So that's a fabulous question. All of us are working in hospitals, have a body of CT scans that are being used to diagnose various medical conditions. And often people with GI disease or cancer, and sometimes trauma patients, have multiple CT scans. The practice of evaluating the abdominal CT for malnutrition requires a skill set. There is an NIH webinar about this that you might search for. I can tell you that it takes about half an hour of your time to map out the muscles that you're going to look at. And we have thought that might not be a real efficient approach. The other thing that's worth keeping in mind is that people are now beginning, radiologists are beginning to use artificial intelligence to define norms. There is a group at Penn, and they're not the only ones, who, excuse me, have from CT scans that were for benign conditions, just pre-op for hernia repair, for example. They have defined the norms, and they're trying to automate being able to scan, having AI scan hundreds of them in a day. So it would be a great skill to have if you have the time to do it. But if these AI approaches take off, then I feel like there will be an automated way to do it, and then we'll have the information. And what's really the best for us is to know how to interpret the data. That's what I think I would do.
Thank you. Next question. Is there a model for GLIM to be used with advanced practice providers where there are not enough dietitians or training programs? And then it was distribution of ONS, et cetera.
Well, we have not made a concerted effort to do that. The GLIM approach has only been defined since 2019, so we're early in the game. We have tried to advertise it, and we're being very consistent about taking a global approach. And I think also because in the US, the Academy has been pushing AIM forward, which is a good thing and which I support completely. But we want not to confuse things by, I don't want to be pushing GLIM in a way that turns people away from the Academy, from the AIM approach, because it's a very organized way of assessing and documenting what you're doing. And I think it's important that we continue that. It may well be that as we get more data with GLIM, we can get to the point of empowering providers in places where there are not enough dietitians. I'm also hopeful that because dietetics is such an exciting career, and because it's among the most desirable new professions for students, I'm hopeful that we won't so often have situations where we don't have dietitians available, because it's really not in the usual scope of work for an advanced practice provider to, even if they have diagnostic privileges, it's not usually in their scope to set up nutrition treatment plans. And when you make a diagnosis, you have to treat the problem. So they two go together. And in terms of insurance, if you diagnose the problem, but you don't have a treatment plan that is tied to it, you will be audited by Medicare. So that's for hospitalized patients. And in the community is a different setting. And I'm not sure that same standard is as severe. But I have to tell you, I teach in a nursing school. We're just about to launch an online Master of Science in Nutrition Science. And we are, the inquiries we're getting are from all kinds of people, from pharmacists, from med students, from nurse practitioners, from entrepreneurs. And we want everybody to be aware of malnutrition, but then the clinical dietitians will be the key experts. And the more people understand, the more highly regarded I think dietitians will be. That's a long way of answering your question. I don't think we're there yet. It's a short way.
Thank you, Charlene. Another question, well, let's just say real quick, I see somebody whose hand is up. I think it's you, Liz, but I can't answer you directly. Wonder if you have a question, if you could put it in the chat. But here's another question for you, Charlene. Have you experienced success with ultrasound use to determine muscle loss in the hospital setting?
So ultrasound is a really interesting approach, and it's new. It's not new. Ultrasound is old, but using it to assess muscle mass is new and still being validated. We were a site at HUP with a group of mostly Canadians and Australians and us who compared the ultrasound of the mid-thigh with bioimpedance analysis measures of the same patient and linked them with some clinical outcome that I'm spacing on right now. It's been 15 years ago, I guess. To do assessment of muscle with ultrasound is also a skill that you can have, and you need to develop great consistency in terms of the amount of pressure that you place on the muscle. So if you're going to do that in your institution, then the whole group needs to be trained and get comfort with the degree of pressure. You don't want to put so much pressure that it's uncomfortable for the patient, but you also want to know that you're getting past the fat layer so that you can see the muscle. This may well be, we compared that to CT scans as I think about it. Marina Mourtsakis was a CT person from Canada who did that analysis. I think that's an approach for the future, and I suggest you keep your eyes peeled for more validation studies because ultrasound is so commonly available. The equipment, every hospital has multiple ultrasound devices, and you can get one of the physicians in your hospital to train you, and then maybe you can train the rest of your team. But I think it holds great promise.
Great, thank you. How can you determine if muscle and fat wasting is related to age-related sarcopenia versus malnutrition?
That's a great question. Because both sarcopenia and malnutrition both have underlying inflammatory mechanisms behind them. The aging would be chronic and probably low, not severe. And we can see some very severe inflammation in hospitalized patients. For example, when patients have a catheter-related bloodstream infection, their C-reactive protein is one of the inflammatory markers that's sometimes measured. I've seen them go up to 30 when normal is less than 7. I would expect that with aging, what you're going to see is a CRP of 8 or 9, something low and chronic. And with age-related sarcopenia is also difficult because people become more they tend to become more sedentary as they age. And so you may get a bit of disuse, atrophy of muscle that's going on too. It's very hard to separate the two. We have tried with GLIM to kind of join the two, and we have had some of the leading authors in the sarcopenia field who've been co-authors in support of GLIM. But saying that we can completely distinguish malnutrition from sarcopenia, I don't think we're there yet. To get there, one of the things that may make the difference is if we can develop metabolomics profiles. Metabolomics is whenever you get a blood sample and you ship it off to a research lab, and they look at all of the breakdown products that are in your blood. And often with these, you can identify the top 10 or the top 30, the most dominant ones. And if we had that level of data, then I'll bet we could see a difference in the signature. Is what the metabolomic signature of someone with severe malnutrition versus age-related sarcopenia. Then, in fact, that would be a fabulous research project to undertake. I hope you will. Or talk to people in your life who do research and see if you can talk them into doing this, because it's important that we know this. And it's also important that we know, is there a different treatment that we ought to do for one versus the other? I mean, as it is, when the weight loss is severe and the inflammation is severe, we tend to think people need more calories and they need more protein. How much more do you need if it's age-related sarcopenia? And what about obesity-related sarcopenia, sarcopenic obesity? That's even harder. So we need a metabolomic signature both for age-related and for sarcopenic obesity that we can compare with these other types of malnutrition. These questions are terrific. These are actually more thought-provoking questions than I've had in other times when I've presented data about malnutrition. So I really do appreciate that.
Well, thank you so much. This was just a fabulous seminar today. I didn't see any other questions come in, so we will be ending. I wanted to announce to everyone that we will be sending out slides and the recording and a CEU certificate for one CEU for all the dietitians who've been on this call. We did have that approved by CDR. So thank you, Charlene. This was an amazing seminar, and thank you everybody for attending today. Appreciate it.
Thanks to all of them. I see some familiar names in the chat. I'm curious, when people don't ask questions, I ask questions. Where are people from? If you could put that in the chat, it would be so interesting to see. Either
Great.
where you work, or are you in Philly, or are you somewhere else? I see Fox Chase, Open Hand Atlanta, MANNA,
Jefferson Transplant, Jefferson, New Jersey, Abram Cancer Center, Inspira Health, Win-Win Community Nutrition Program.
This is one reason why the diversity of the questions with this group have been so great, because of where you're coming. We have a really good chance of dealing with this problem of malnutrition if we have all of these people moving forward with the charge. So thank you all for sharing. This is awesome.
Great. Thank you, everyone. We appreciate it, and we do these twice a year. So hope you'll join us again in the spring. So if you're on this webinar, you'll be on our mailing list. So thank you again. Bye-bye.